Due to COVID, this time it is BYOB. But we hope everybody brought a favorite snack, and we hope to make it up to you in the future with more drinks and dialogue. One advantage, however, of moving to a Zoom event is that it does remove the impediment of geography. So I wish to welcome all of you here tonight from all kinds of different places. So of course, Colorado, but also Florida and Texas, California, Arizona, Massachusetts, Michigan, and Maryland, to name just a few. So we have folks here from all over, and welcome. I also want to say that we are extremely grateful to the State League of Colorado and its director, Beth Hendricks, for all their help in putting on this event and allowing us to use their much larger Zoom platform. So thank you, Colorado State League. This evening, we are very lucky to have Dr. Eric Toner. Dr. Toner is a senior scholar with the Johns Hopkins Center for Health and Security. He's an internist and an emergency physician. During the COVID-19 pandemic, he has authored numerous reports and journal articles, including those describing hospital preparedness, estimating national personal protective equipment needs, and proposing an ethical framework for the allocation of scarce COVID-19 vaccines. He works closely with the federal government on pandemic issues, and he's been interviewed frequently by major national and international news media. Just as an aside, he even found time a few years ago to consult with Hollywood on the movie Contagion. So it is our very great pleasure to welcome you here tonight, Dr. Toner. Just as a reminder, we ask that people keep their mics muted. If you have questions for Dr. Toner that you haven't already submitted, write them in the chat box, and he will field as many as he can at the end of this talk. With no further ado, welcome, Dr. Toner. We wish we could show you the mountains of Colorado in person, but we'll have to do it another time. So welcome.
Well, thank you, Barb. I appreciate that kind introduction, and hello, everybody in Colorado and everywhere else. It's good to be with you this evening. I'm going to share my screen if this works correctly. Okay, is that showing up all right, Barb?
Yeah, it is for me.
Okay, good, thank you. So what I'm going to do over the next hour is give you an overview of COVID-19, starting with some very basics, where it came from, where we are now, looking at the global picture, and then down to eventually getting down to Chaffee County, talk about some of the breaking hot button issues of the day. Then we'll eventually look in my crystal ball, and I'm going to tell you precisely what's going to happen from now on. And I hope to leave plenty of time for questions and answers. So first things first, COVID-19 is short for coronavirus disease 2019. It was named because that was the year discovered. It's caused by a virus. It's called the SARS-CoV-2 virus. It's called that because it's very similar to the virus that caused the SARS outbreak in China in 2003. Why is it called a coronavirus? Because when you look at it under an electron microscope, it looks like a crown. There are 7 human coronaviruses. COVID-19, or the SARS-CoV-2, is just the newest one. There was also the SARS-CoV-1, the virus that caused SARS in 2003. The MERS-CoV, the one that is still causing Middle East respiratory syndrome in Arabia. And there are 4 common cold coronaviruses, which have been around as long as we've been able to know anything about viruses. So the pandemic began a little over a year ago. late December of 2019, there was a cluster of 27 cases of viral pneumonia in Wuhan, China. All the diagnostic tests were negative, and eventually it was discovered that this was a novel virus, a new virus. So in mid-January, the virus was identified, the genetic sequence was published, and just about the same week, first cases appeared in Europe and in the US. On January 21st, last January 21st, not this one, the one before, Wuhan and Hubei province were locked down with a lockdown more strict than anything that has been experienced before or since. So this is a graph of cases, daily cases in Wuhan. Here is the beginning. And so each of these dots is a day with a number of cases. So up to here, so in just 2 weeks, on 45,000 cases. At that point, the city was locked down. Took a couple weeks for that to take effect. But in the first month, there were 72,000 cases in the city of Wuhan. But the lockdown worked. Cases leveled off and have remained essentially level ever since that time. So this is a graph of global cases. And I'll start by showing you that the 72,000 cases in Wuhan don't even show up on this. It's too small for this scale. So we've just reached a peak. We're now on the downslope of this peak that was started about 2 weeks ago. We are at now cumulatively 101 million cases around the world. This is a gross underestimate. The number of actual cases is many times this. So we are now seeing, on average, somewhere about 700, we were seeing about 700,000 new cases every day. We're now down to about 600,000 new cases every day. Still a lot. So these are global daily deaths from the disease. This has not peaked yet, it's still going up. So we are at about 14,000 deaths per day from COVID-19. So far, cumulatively since the beginning of the pandemic, we're at 2.1 million deaths. And these are the current hotspots. All of this data is from today. The US, as it has been since the spring, remains one of the top countries in terms of severity of disease per capita. We have almost more cases. We have the most cases in the world, but we have a large population. We're always amongst the top 4 or 5 in terms of cases per capita. Spain is having a particularly bad outbreak right now. Some of the countries in Central Europe are. England has been having a lot of problems. Brazil's been having a lot of problems. No place in Asia is having any problems, and none of them have had for many, many months now. So looking at the US picture, in the pink here are cases per day. So as I said, we peaked about 3 weeks ago. This was the holiday peak, Thanksgiving, Christmas, New Year's peak. And we're now on the downslope from that. Cumulatively, we've had just about 26 million cases in the US. Again, this is a significant underestimate. Many more cases that were never detected, never tested. And we're going at right now at about 140, 150,000 new cases per day in the US. In terms of deaths, again, it has not peaked. We're still going up. We've had now about 430,000 deaths in the US, and we're running at about 3,000 deaths per day. So Colorado. So this is Colorado's cases. in pink, the curve. So Colorado had a big peak in mid-November, and then it tailed off. We had another little spike related to the holidays, no doubt, and that's now coming down. Cumulatively in Colorado, there have been 392,000 cases and 5,648 deaths in Colorado. In Chaffee County, there have been 1,274 cases so far, 6 cases in the last 7 days. And each time I look at this, this looks to be about the same number. It seems like you're having a death a day on average. So current US hotspots, again, this is today's map. Southern California is bad, but better than it was. Arizona remains pretty bad, but better than it was. Parts of Texas are bad. Georgia, parts of South Carolina are bad. There are lots of little rural counties around the Midwest and the Plain States that look bad. These are a little bit artifactual because it doesn't take anything more than a few cases in these counties that have very few people to make their per capita numbers look pretty bad. So hospitals have been overwhelmed everywhere, most recently really bad in California and in Arizona. Previously, as I'm sure many of you know, in the spring in New York City, it was terrible, but it was just about equally bad in San Diego and Los Angeles just in the last few weeks. So this is a graph of number of people in the hospital. So you can see the spring wave, the summer wave, and the much bigger wave, the biggest wave we've seen in the last few weeks, just peaked after the holidays. But still, we're still quite high in terms of number of cases. So in the hospitals, there have been shortages of supplies, of beds, and staff. Staff has been the biggest problem, particularly trained intensive care doctors and nurses. There's been a critical problem in California with oxygen. Hospitals have had trouble maintaining an adequate supply of oxygen, and oxygen is the main treatment for COVID-19. And with hospitals being overwhelmed, they haven't been able to maintain the normal standards of care that people would expect when they go to a first world hospital. And as a consequence, in the communities in which the hospitals are severely stressed like this, fatality rates have soared, and in many cases doubled. That's true for COVID patients. It's also true for non-COVID patients. So the disease, the COVID-19 disease. So you hear lots of different things about COVID-19. You hear it's terrible. You hear it's just the flu. It's just a cold. So here's the real poop. About 25% of people have no symptoms, never have any symptoms. About 30% of people have a very mild illness that they would describe as being like a cold. Lasts a few days, have a little cough, a little sore throat. It's really a big nothing. So that's more than half the people have a very mild illness. 30% of people say it's the worst flu of their life. It's an illness that they will never forget. They were so sick, they've never been so sick before. About 12% of the people require hospitalization. It's mostly because their oxygen levels have fallen so low, and they need to be in the hospital to get oxygen. About 3%, so a small percentage, but a large number because we're talking about millions of people, 3% require intensive care, and about 0.5% die. So, it's a small percentage, but a big number when looking at a national or global scale. Of those people that have anything more than just the mild cold symptoms, about 80% of them reports having persistent symptoms 6 months after their illness they've gotten better. These are the people that are now being called long haulers. They have a variety of symptoms. Some have trouble breathing, some have trouble thinking, nearly all of them have fatigue and muscle aches. So age is the greatest risk factor for serious illness. On this graph, you can see age on this side going up to 85 plus. And this is across here, the death rate per 100,000 population. So you can see if you're 85 and plus, you are roughly 3 times as likely to die of this disease as if you were in your 70s. And that's about 3 times as likely as if you're in your 60s. If you're down in your 20s and below, your chance of dying of this disease doesn't register on this graph. So it is very much driven by age in most cases. But there are some underlying health conditions that put even young people at some risk. Obesity is one. Immunosuppression is another. And that can be immunosuppression from either an underlying disease, cancer chemotherapy, high-dose steroids for another disease, transplantation with immunosuppressive therapy to prevent rejection. There are a lot of people in the US who are immunosuppressed for one reason or another. They're all at some risk. Anybody with significant chronic kidney, lung, or cardiovascular disease is at increased risk. People with neurological disorders, and that can be people with strokes, people with congenital problems such as cerebral palsy, people with who have various degenerative diseases are at greater risk. And people who are diabetic are at greater risk. But none of these conditions put you at as great a risk as simply being older. Age is the #1 risk factor. So let's turn to treatments. So there are a bunch of different treatments. Some you've heard about, some you may not have. So the first ones are monoclonal antibodies. There are now 2 companies that make these monoclonal antibodies. So these are antibodies made in the laboratory, antibodies that are specific to this virus, and they're made in a laboratory. And they're infused through an intravenous infusion over a course of about an hour. And these are used for people who have symptoms, but are not so sick they need to be hospitalized. And in people who get these infusions, their risk for hospitalization is cut basically in about half. And they tend to get better than, they get better more quickly than people who've not had this treatment. It's not traumatic, but it helps. There have also been some studies that have come out in the last week or so that showed that in people who are at very high risk, so in nursing homes, residents who are not sick but have been exposed to another resident who is sick, that these can prevent illness. So this is not a therapy that's been used widely yet. It's being used more and more. The biggest problem is it has to be an infusion. And so we have to have infusion centers set up to do this. That is just beginning to happen now. Convalescent plasma, that is blood taken from somebody who's recovered. And then all the cells are removed, just leaving essentially the plasma and antibodies. These have been tried. The results are not dramatic, but it is an approved therapy, and it is being used to some extent. There's an antiviral drug, remdesivir, which was approved in the spring. It is effective for people who are sick enough to be in the hospital, but not sick enough to be in the intensive care unit. It's helpful. It's not dramatic, but it's helpful. Steroids, specifically dexamethasone, but other steroids work as well. They work for people who are sick enough to be in the intensive care unit. They don't work for people who are not that sick. In fact, they may increase the risk to people who don't need it. And another thing is that we've discovered over the course of the last year new approaches to ventilation. We've learned that putting people on their bellies rather than on their backs improves their ventilation. We've learned that not everybody needs to be on mechanical ventilator whose oxygen levels are low. And there have been new approaches to some of the technicalities of how we do mechanical ventilation. So all of these therapies together have reduced the mortality, the in-hospital mortality, by as much as 50%, which is great. It's reduced the burden, it's saved many lives, and it's reduced the burden on the hospitals. So, the topic of my day, all day, every day, is vaccines. So we have 2 vaccines right now, which have been approved, Pfizer and the Moderna vaccines. These are both messenger RNA vaccines. That is a piece of nucleic acid, a piece of RNA is made in a laboratory that is based on the sequence from the virus. And when injected into you, it tells your cells to start making the protein that the virus has on its surface. So it's a way of telling your own body to start making its own vaccine. This is an entirely new approach to vaccines. These are the first RNA vaccines, and they're very effective, 95% effective in reducing illness. Their biggest problem is RNA is very unstable, so they have to be kept very cold. The Pfizer vaccine has to be kept at 90 degrees below zero. The Moderna vaccine, not quite so cold, but that creates logistics problems. You can't administer these vaccines through a doctor's office if they need to be kept at 90 degrees below zero. The Johnson & Johnson vaccine is very interesting and exciting because it, unlike the 2 that I just mentioned, the Pfizer and Moderna vaccines, they both require 2 shots several weeks apart. The Johnson & Johnson vaccine is a 1-shot vaccine, and it doesn't require a cold chain. So it could be delivered through every pharmacy in the country. It could be delivered through doctor's offices in the country. It can be delivered everywhere where we normally get vaccines. It can be delivered just like flu vaccines. It will be going before the FDA in the next couple weeks. Looks like it probably should get approved. And we think that this vaccine will probably start being rolled out maybe around the 1st of March. There are 2 other vaccines which are likely to come within the next 6 months or so, the AstraZeneca and Novavax vaccines. Both of these are also 2-shot vaccines, but they're promising. We need all of these vaccines if we want to get to the goal of having most of the country vaccinated by the summer, which is the stated goal. We should have enough of these vaccines. We have a lot of vaccine, and we have millions of doses of each of these vaccines, or we will have millions of doses. So how are we doing in vaccination? So if you talk to your friends and you listen to the news, you think we're doing a terrible job with vaccination. I have to tell you, that's not really true. This graph in red is how many vaccines have been administered. So if we look at the beginning of January, we are at just a little over 200,000 vaccinations per day. In the last 10 days or so, we've been averaging between 1.2 and 1.6 million doses per day. President Biden had said his goal was 1 million doses per day in the first 100 days. We're already past that. We were past that before Inauguration Day. So we're doing okay. And we vaccinated well over 20 million people so far. But it's not all rosy. The problem is that 1 million doses a day isn't going to get us to vaccinating the whole population by the summer. We have to get up to about 3 million doses a day. So we expect more doses coming from both Moderna and Pfizer. We expect the Johnson & Johnson vaccine to come in the next month or 6 weeks. So there is confidence that we're going to get there, but it's going to take some time. So this is a map of vaccinations, what percentage of the population of each state has been vaccinated. And as you can see, Colorado is sort of in the middle, sort of average in terms of the percentage of the population that's been vaccinated. So far in Colorado, there have been almost 500,000 doses administered, which is slightly better per capita than the national average. But while we wait for the vaccines to come on board and for all of us to get vaccinated, we can't forget about the public health measures. And these are the things that we know really work. Properly wearing a mask in public. If everybody wears a mask properly, that is covering your nose and your mouth, not your hair nor your chin, really works. Maintaining distance works. Avoiding crowded indoor spaces works. Washing your hands works. Widespread testing with rapid results coupled with isolation and quarantine really works. Tests that take 2 weeks to come back are not worth doing. Contact tracing works, but only if the prevalence of disease is quite low. We have too many cases by far to be able to effectively do contact tracing. So these work, but they only work if the people do them. So where do we think we're going? So the estimates, and this is from the group in Seattle, the estimate that they have is for 569,000 US deaths by May 1st, 3.3 million globally. The CDC is estimating, CDC and other modelers only look out about 4 weeks. So CDC is looking at about 500,000 deaths by the end of February. And I think that is conservative. So these are really big numbers. It's hard to really grab hold of them. So let's put this in some context. Right now, COVID-19 is the third leading cause of death in the United States, second, following only heart disease and cancer. The average number of people who die per year of flu is 27,000. So this is 20 times that. So comparing this to other historical events, In the Civil War, there are 750,000 deaths over 4 years. More people have died from COVID-19 than in any year of the Civil War. The 1918 flu pandemic killed 675,000. We could well approach that number. World War II, US military deaths were 417,000. So we've already passed that. The biggest natural disaster in US history was 10,000 deaths. 9/11, D-Day, Pearl Harbor were all in a 2,000 to 3,000 deaths range. We see that every day now. So an area of a lot of concern and attention now are the new variants. So they're basically four. The one you've heard most about is the UK strain, the B.1.117 strain. It is pretty clear that it is more contagious than the predominant strain of COVID-19 or the SARS-CoV-2 virus. It is probably about 50% more contagious. It is probably also more virulent. That is, it causes more severe disease on average, maybe on the order of 30% more virulent. So it causes more illness and causes more severe illness. There's a South African strain, which is also more contagious. It's not clear that it's any more virulent, but it appears to be less sensitive to the existing vaccines. How much is uncertain. The studies of it are early, but it may be 30% less sensitive to the existing vaccines. So the companies are already developing new strategies to deal with this. Two strategies are being considered. One is to add a third shot to the 2-shot regimen right now, and the other is to add a new strain. Either of those approaches would require 3 shots. The 2 shots people are getting now, plus an additional shot. There's also a mutant strain in Brazil, which has caused large outbreaks in the city of Manaus. And there was a strain in Denmark that caused an epidemic amongst minks. And one of the many new and interesting things I've learned in this job is Denmark is the world's leading producer of mink. And so this caused an outbreak in mink and to some extent in people, but not a lot in people. But it led to the culling of all the minks in Denmark. But all of these strains have now been found in the US. The UK strain has been found in 28 states. The South African strain was just discovered in 2 people in South Carolina who had not traveled and did not know each other. The Brazilian strain has been found in Minnesota. And the Denmark strain has now been found to cause about 25% of all the cases in the San Francisco Bay Area. The UK strain is expected to become the predominant strain in the US within the next 2 or 3 months. So we are expecting that there will be another surge of cases coming as this strain becomes more widespread. The good news is that all of the measures that we take to reduce the risk of spread, again, masking, distancing, avoiding crowded indoor spaces, all of these will be effective against any of these strains. So here's what you've all been waiting for. How and when will this end? It won't be sudden. There won't be a bell that goes off that says that this is all over. We won't even know that we've reached herd immunity in real time. We'll be able to tell you that a year from now when we look retrospectively at the data. So what will we know? We will know that the number of cases is going down and gets very low. So as more and more people are vaccinated, the number of cases will gradually decrease. And at some point, we will see the number of cases be very low. And as that happens, contact tracing will become more effective, business restrictions will be relaxed, schools will be reopened, we'll be going to restaurants, we'll be going back to movie theaters. This will all happen gradually, a bit at a time, and it won't be the same everywhere because the trough in cases, the low number of cases, will be coming at different times in different locations. But we will reach a point. My guess is over the summer, when we've reached this, a very low number of cases. But COVID-19 is not going away. There's no hope to eradicate it. The hope is that we can get it down to a point where it doesn't cause large outbreaks, that there will be periodic cases of it here and there, maybe small clusters of cases, but they're manageable and they don't keep people from doing anything differently than we normally do, except for two things. One is I think that we will continue to be vaccinating for COVID-19 for as far into the future as we can see. New people who haven't been vaccinated will need to be vaccinated. Eventually, children will be vaccinated. It's quite likely that we'll need to have booster shots along the way. So COVID-19 vaccination will be an ongoing effort for forever. I also think and hope that mask wearing and self-isolation, if you're sick, become the norm. If you have the flu, if you have a cold, I think we now should expect that you wear a mask. That's what they've done in Asia for many, many years. It just makes good sense. You may have noticed there's been no flu this year. There's also been very little in the way of common colds this year. Respiratory illnesses have disappeared except for COVID-19. And why is that? It's because we're wearing masks and we're maintaining distance and we're avoiding crowded spaces. These things prevent the spread of all respiratory viruses. So I don't think it's a bad idea to consider doing these things going forward. Not all the time, but when you're sick or when there's an outbreak of something, I think it makes sense. And with that, I'd be happy to take your questions and see if I can come up with an answer.
All right. Well, we have a lot of questions. So I will just start with the ones that we have. You've answered several that we got at the beginning. So here's a couple of questions. One is the question, first of all, can somebody who has been vaccinated still carry COVID? And are other people safe to be around you once you are vaccinated?
The answer is we don't know. And therefore the recommendation is that even if you're vaccinated, you should still wear a mask, because the trials that test the vaccines don't test for contagiousness. They just test for whether you get ill or not. So it is possible to still spread the virus even if you don't actually manifest an illness. We don't know to the extent, we don't know whether this happens at all, and if it does, we don't know the extent of it. We will eventually figure that out as more studies go on, but we don't know that right now. So you should presume that you're still infectious and wear a mask.
Okay, and if you are with people who all have been vaccinated, there's of course some interest in this because a fair number of people in Chaffey County have now been all vaccinated. Is it safe for you to socialize with them?
I think
indoors or only outdoors, or which way?
I think if you know that everybody has been vaccinated, right, and you're sure that's the case, and we have to remember that vaccines aren't effective the moment you get vaccinated. So it takes a couple weeks after your second shot before you've reached full immunity. Then you probably are safe to be together with other people. I'm sure that the official recommendation will still say to wear a mask, but you should be safe.
Okay, and there was a second part of that is that if the vaccine is said to be 95% effective, and you've received both vaccine doses, does that still mean that there's a 5% or 1 in 20 chance that you could get COVID?
Yes.
Right.
Yes. But of the people who got COVID in the trial, the people who were vaccinated, who got COVID in the trials, only one person had a severe illness. The rest had very mild, had relatively mild illnesses. So it protects against illness, and it also protects against severe illness.
Okay. All right, good to know. Let's see. I think another question that came up is that some people have gotten sick from the second shot, but not the first shot. And why is that?
Well, it's happened to everybody I know, happened to me, and happened to all of my friends and colleagues. Yes. And we knew about this in advance. We knew about this since early on in the trials, that for both vaccines, particularly the Moderna vaccine, but also for the Pfizer vaccines, that with the second shot, you have a lot of transient side effects. For the most part, lasting a day or less. Typically, you feel like you've had the flu, or you're really tired, and it's the manifestation of your immune system responding to the vaccine. So when you get your first shot, your immune system's never seen the vaccine, and you don't have a real robust reaction to it. When you get your second shot, your immune system's already been primed, so it is ready or raring to go to respond to that second exposure to the antigen. And so what can help you during that one day when you feel like you got kicked by a mule is that you know that that's your immune system that's kicking you, and it's a good thing.
Okay, there's also a question on, you talked about how low the rates are in Asia where the virus started, but are now really, really low. What do you mainly attribute that to? Why are their rates so much lower than ours?
Because they did a really good job of controlling the disease at the beginning. They were aggressive in their quarantining. They had ubiquitous testing. Everybody was tested. They had good tests from day one, and they had a very compliant population that when asked to quarantine, did quarantine. When asked to get tested, did get tested, and they had really robust contact tracing. Remember, these countries were severely affected by SARS, so they learned a tough lesson in 2003. So they were well prepared for this, but they showed what could really happen. And so now, whenever there's an imported case, they just jump all over it, and people are quarantined. The sick people are isolated. They trace all the contacts very quickly, and they've been able to contain every little outbreak that they've had. And so they've had very little.
Uh-huh. Okay, there's been things written that if everybody wore either double masked or wore an N95 mask, that would stop the disease in its tracks. Do you think it's necessary to be wearing N95 masks or double masking?
I don't think it's necessary. What's necessary is that you wear a well-fitting mask properly. So, you want a mask. So we need to get rid of the bandanas. We probably need to get rid of the gaiters. And people should wear proper masks, whether they're cloth or whether they're, these pseudo medical masks that you can buy in the drugstore. They're both reasonably effective if they fit properly and if you wear them properly. Would you get more filtration if you wore multiple masks? Yes, but it's also harder to breathe. And so if we make it too hard to breathe, and what's going to happen is you're going to suck in air around the mask rather than through the mask. So I think there's a danger in everybody just going to double masking. I do think if you do it properly, it can solve some of the problems with fit that we have with some of the masks. But I don't think it's a panacea. And I don't think that everybody needs to run out and start wearing 2 masks.
Good, thank you. If you have had COVID, or do you still need to be vaccinated for COVID?
Recommendation is that you do get vaccinated, even if you've had a documented illness from COVID. They recommend that you wait 90 days after your illness before the vaccination. The reason for this is we're not sure how long immunity lasts from after an infection. We don't know how long immunity lasts after a vaccination either, for that matter. But the thought is it couldn't hurt and could boost the duration of your immunity.
Okay. There have been rumors and there's been things written that the virus started as a bioterrorism escaped from a Chinese lab rather than a live market. Is there any evidence to that?
Well, I think that question conflates 2 things. So I don't think there's any evidence that this was a bioterrorist event. That doesn't really make any sense. The theory about an escape from a laboratory is a possibility. So that there are several laboratories, particularly one in Wuhan, that does research on COVID, on coronavirus vaccines. Because ever since SARS, they've been very concerned about a new coronavirus. So they've been doing research to develop coronavirus vaccines there. And they work with live virus. And so no one can yet say it didn't escape from that laboratory, but no one can say yet that it did either. It is quite likely that this, like other emerging infectious diseases, emerged from animals, from bats. We know all of these coronaviruses come from bats. So what we can't be sure at this point is whether it came from a bat and into people directly or through another animal or through a laboratory. We haven't been able to determine that. And we may or may not ever be able to determine that.
Interesting. Somebody asked how much impact has the misappropriation of funds from the research branch of HHS impacted our current response?
None, that's a separate problem. that's that's a separate problem. That's a problem that's been going on for at least a decade. That everybody, working with HHS has known about and complained about for years, and but that had nothing to do with. There are many things that went wrong with this pandemic response, but that was not one of them. That's a separate screw up.
Do you have a sense of what you think the Biden administration and others are going to do to begin to strengthen public health systems in this country? Because it seems like that has been a problem, that we've just not invested and dismantled what we had.
Yeah, so we've been neglecting public health for decades now, and there have been several attempts to reverse that. There was a big bill in 2005 and 6 to put money into public health. We were going to spend all this money to recruit new workers into public health, to pay for education, and all the bills are great. The money never gets appropriated, and nothing much has happened. So I hope that we do something this time. It would be a crying shame if we don't, but it's going to depend on Congress. I'm 100% sure that the Biden administration will want to have more money to do this, but they don't control the purse strings. So it would need to be a new appropriation from Congress. And in these days you can't be sure.
Right. Okay, the other question that has come up is that that there are 3 vaccines that haven't come on the market. What is the difference between them? They are not all mRNA vaccines, and are they all equal in effectiveness?
Yeah, so there are three vaccines that are not yet on the market that are ones that we anticipate coming. There are actually over 200 vaccines, COVID vaccines, in various stages of development, and there are a variety of COVID vaccines that are being used in other countries. These are just the ones that we're talking about for the US. So the other 3, the Johnson & Johnson, AstraZeneca, and Novavax, they are not mRNA vaccines. They use more traditional technologies. None of them require the extreme cold chain, and the Johnson & Johnson vaccine is just a single shot. The other 2 would be 2 shots. We don't know yet how effective they are because they're still in clinical trials. And so they've all looked reasonably good in their phase 1 trials, their initial trials. They all seem safe and at least passed the early test for effectiveness, but we won't really know how effective they are until they've gotten through the final trials, the phase 3 trials. We expect to see the data from Johnson & Johnson in the next couple of weeks. The others will be later than that.
Very good. Also, as somebody that rumors that fly around is that there have been accusations of the over attribution of deaths to COVID, and that the numbers in the US are escalated compared to those reported in other countries. Any notions on those?
That's completely backwards. The number of cases in the US and globally is a gross underestimate of the actual number of cases. We know this from the daily mortality studies or records that many countries keep. We know that the number of people who've died during the pandemic is way out of proportion to normal and much larger than the number of known reported cases of COVID-19. The same thing has been found in essentially every country where it's been looked at. So we also know from serologic studies, that is testing people for antibodies to the virus to see if they've been infected, that the percentage of people who've had a prior infection is much greater than the number of people who we had known to be infected by having a positive COVID test. So there are many more cases of people sickened and dying from COVID than our records would indicate.
All right. And also, what is your response to people who object to the vaccine being mandatory? And are there people who legitimately should not be vaccinated?
Well, the vaccine is not mandatory. In no place is it mandatory because it's still under emergency use authorization. So it's not a licensed product yet. So no one could legally mandate an unlicensed product. In fact, when you get vaccinated, you have to sign a waiver stating that you know that you're being given an experimental product. So nowhere is it mandatory. It's recommended, but it's not mandatory. Could an employer, once it is fully licensed, mandate it? Yes, they can. If they have reason to think that it's important for your work to be vaccinated, yes, they could mandate it. That has generally not gone very well. Sometimes it has, some have, but I take it back. So if you work in a hospital, you're required to have, be tested for TB, you're required to have hepatitis B and hepatitis A vaccine and you're required to have tetanus. And if you don't, you can't work there. They could do that for COVID-19. There have been some hospitals that mandate flu vaccines. That has not gone as well in many places. Staff have pushed back. So I'm not sure how many places would ever mandate it, but they can't right now.
Are there people that shouldn't be vaccinated?
The only people who shouldn't be vaccinated right now are people who are known to have had a severe allergy to the first vaccine. They should not get the second vaccine. But those incidents of severe allergic reactions is really it's tiny. It's a tiny fraction of a tiny fraction. Otherwise, there aren't really any contraindications for not getting vaccinated, or for avoiding vaccination.
Okay, we'll just take a couple more because we are running out of time. But first of all, how accurate is the COVID rapid test?
Well, that's a hard question because there are so many rapid tests, well over 100 different tests, and so they're all different. Some of them are pretty good. Some of them are awful. And so you really have to know what test it is. And, that's an awful lot to ask of a layperson to try and figure out what test they're getting, even if you could find that out. So that's a hard question to answer. Some rapid tests are pretty good. Some are okay. It also depends on what question you're trying to answer. Are you trying to answer the question, are you contagious? They're better for answering that question than they are for answering the question of, have you been exposed to COVID-19? Because that, in response to that question, the tests are not as reliable. But are you contagious at the time that the test is taken? They're pretty good for that.
Okay, and then there's a question about what are your thoughts on the mutant strain from California, Cal 20C?
I'm not sure what that one that is.
We'll
Okay.
have to
I-
look
I-
into it. All
Yeah,
right, then I will just ask you one. Yeah. It's probably from the California contingent here. Okay, there were a few months ago, there were studies about blood types being more or less susceptible to the virus. Do you give any credence to that?
Yes, it seems to be true. People who are type O are marginally less susceptible to infection, and if infected, seem marginally less likely to have severe illness. But it's really a very small difference. So if you know your blood type, you know that I wouldn't spend a lot of time either being comforted by it or worrying about it.
Okay. Okay, and finally, do you think healthcare workers will get better recognition and compensation after all this is over?
No.
Sadly.
Yeah,
But
sadly, yeah. I do think a lot of
you
I
do.
do think a lot of healthcare workers are going to leave the field. I think healthcare workers across the country and around the world have been brutalized by this experience. I mean, this is in every way for many of them quite comparable to going to war. PTSD is rampant amongst hospital workers, and I think many of them are and will continue to leave the field. I think we're going to have a real problem with rebuilding our medical workforce.
All right. Well, we thank you. I've got one new message. We thank you so much for your time, and we encourage you to go to our website and where you can see about, if you're local, see about membership and becoming part of the league. And we so appreciate your time, Dr. Toner. This has just been really, really informative, and hopefully people got some of their questions answered. There is always more. So we sure appreciate your time. We know you're very busy. So thank you very much, everybody. And thank everybody for coming.
You're very welcome. Take care, everybody.
All right. Thanks so much. Bye-bye.